Hi, everybody. We're going to just wait a couple more minutes for some other people to join, and then we'll go ahead and we'll get started. I don't see Dr. Adai here yet. Do you want to wait to get started till he logs in?
I mean, I think I can run through the cases. They're like embedded in the presentation. So if he doesn't get here by then, I'll just keep an eye out for him. Hopefully I'll be able to see all of the, actually, I'll just send him a chat to pipe up when he gets in.
Okay. Perfect.
Oh, I don't think I can, but I'll just keep an eye out for him.
Okay, great. And I'll have my eye on the waiting room. But all right, why don't we go ahead and get started? All right, well, thank you all for joining us this morning. This is Dr. Hadley Wood, and she is a professor of urology at the Cleveland Clinic. And her specialty interests include genital and urinary reconstruction with a special focus on adolescents and adults with congenital anomalies of the urinary tract. Her lecture topic today is going to be on urodynamics and congenital neuropathic bladder. So without further ado, I'll let Dr. Wood take over.
Okay, can you hear me? Am I off mute? I'm off mute, right?
Yes, we can hear you.
Okay, perfect. Good morning, everyone, or good afternoon to those of you that are not in this time zone. I am going to, I just want to see, Danielle, can you keep an eye on the chat? And if any questions come up, can you just stop and we can address them as we go along?
Yeah, absolutely.
I'd like to keep this sort of pretty loose and let people, it doesn't look like there are that many people, so we can, because I can't see how I can have the chat in view and also all the people. So
yeah, I can keep an eye on it, no problem.
All right, so this morning we're going to talk a little bit about urodynamics and both congenital and to some extent acquired neuropathic bladder. I have never been to Uganda. I've been to Rwanda and saw a little bit of neuropathic bladder there. And the lack of functioning urodynamics made it really challenging. So when I thought about putting this talk together, I thought about, well, what are the clues that we can use in the history and with the patterns that we see with different pathophysiologies that would help guide us to when measuring bladder pressures would be really critical. So we'll talk a little bit about what urodynamics is, and then ways that I use it in my clinical practice, and it can be used more broadly. What the setup is like, and then we'll do a couple of cases that Dr. Adai, if he can join us, had sent me from his practice, and he'll share. And then we'll just talk a little bit about treatments. I also have a video that's completely unedited. I just went down and videotaped one of our urodynamic nurses doing a study and asked her sort of questions to prompt her to show what the setup looks like. It's about 8 minutes or so, so it might be too long to show to this, but I could put it on at the end. I have clinic to get to, but I can put it on at the end if anybody wants to watch it, or I can make it available to Danielle. So just sort of broadly, when we think about urodynamics, there are a couple of things it tells us. Number one, it tells us how the bladder stores, at what pressure the bladder stores, how stable the bladder is during the filling phase, and what the sensations are. And then it also tells us sort of how it empties. So when we think about urodynamics, we sort of think of the two phases, storage and emptying. And those are broadly categorized into the CMG phase and to the pressure void phase. And importantly, not just how, as it empties, like how it mounts a pressure, but also how, particularly with video urodynamics or needle EMGs, how it coordinates with the bladder neck and the sphincter. And so again, these are the phases. Typically, we start by just doing standard uroflow, which is having a patient urinate into a flow measuring device without the catheter in, which is a measure of emptying. And then the two phases that include the catheters in both the bladder and in intra-abdominal pressure, which is typically in the rectum, that measures the CMG phase, which is the storage phase, and the emptying phase, which is the pressure flow study. So this is a photograph or a pictorial given to me by one of my partners who's a biomedical engineer here, who's actually working on ambulatory CMG techniques so that we can install these into patients and send them out and measure their pressures through longer durations than just a study in the lab. And this is sort of an old school CMG. What you see is a patient laying on the table with a pressure monitor in the bladder, and then the bladder, the water is filled, and the pressure in the column of water pressure is measured. And that's sort of just roughly what it is. But of course, our new technology, our current technology allows for this to be a little bit more sophisticated. And so to really understand urodynamics, you need to understand sort of where the pressures are, what the pressures are that we talk about. So one we talk about is the PDET, which is the detrusor pressure. And that's roughly, the pressure that the detrusor muscle itself, irrespective of the abdominal pressure, can generate. So that's sort of shown here. And then PABS, which is the pressure that can be generated around the bladder. So as with a cough, or with a Valsalva or Crede maneuver. And so in general, the pressure that the bladder sees is an additive pressure between the detrusor pressure and the abdominal pressure, if you sort of think of vectors. And so what we're doing when we measure, I'll show you the setup and we'll get a little bit more clarity around that. And so why is it important to sort of think about these different pressures? It's because the different pressures portend different types of leakage of urine and also different treatments. So if we're talking about incontinence, which is a major reason why we use urodynamics in my practice, we think of overflow, which is just the bladder's full and cannot empty. But we think of stress incontinence, which is typically abdominal pressure that overrides the sphincteric resistance, and urge incontinence, which is more related to storage, to the detrusor pressures or phasic contractions during filling. And of course, the treatments are different. The patient has overflow incontinence, and you treat this by relieving the obstruction, either with a TURP or a urethrotomy or a catheter. If the patient has stress incontinence, which is commonly seen following prostatectomy, or other similar procedures, then they get a sling or an artificial sphincter. And if the patient has urge incontinence, we typically treat that first with behavioral modifications, medications, typically the antimuscarinics, and then botulinum toxin injections or fancier things like suprapubic tuber augmentation. And this is sort of a representation of what the setup looks like. So the patient will have one catheter, which is about 7 French, 6 or 7 French, just depending on what you use, placed in the bladder. And there's a pressure transducer at the end. This particular catheter has 2 channels. It has a measurement channel, and then it also has a pump. So there are two pieces to that, but it's all in one catheter. And then there's a another second catheter that's placed in the intra-abdominal to measure intra-abdominal catheter pressure, typically in the rectum, but a patient who, for example, may have had an abdominal perineal resection or may have something else You can place it in a ostomy, like in a colostomy. You can place it in the vagina in a female patient. So it just has to measure the pressures that are generated around the bladder. And then urine or water or contrast, if you're doing video urodynamics, is slowly pumped into the bladder. And these three pressures are measured. So the abdominal pressure is measured by the rectal catheter. The vesicular pressure is measured by the one that's in the bladder. And then the detrusor pressure is a subtracted pressure of the vesicular pressure minus the abdominal pressure. And so the patient reports when they're feeling the sensations, and then at the time of bladder emptying, we'll get to some graphs so I can sort of walk you through what that looks like. When we think about neurogenic bladder, I don't really like the term neurogenic bladder because it's really sort of a wastebasket definition. It really means any effect on the bladder that is caused by a neurologic injury. And so obviously, when you think about any neurologic injury, we always sort of classify them into upper motor neuron, lower motor neuron, sensory, and motor. And so those different types of injuries can manifest very differently on the bladder. And I just have a picture that sort of explains, some of these things, how we think about them: stroke or dementia, tumors of the brain. Multiple sclerosis can happen anywhere along the central nervous system, so in the spine as well as the brain. And then things that happen lower down in the lumbar and sacral, things like injuries to the sacrum from MVAs, traumatic injuries, tumors, spina bifida sometimes can happen this low, and spinal injuries. But then also low sort of things that we sort of classically think of as lower motor neuron injuries, which result from pelvic surgery, diabetes, sometimes traumatic childbirth. And then of course, the way that these manifest, what manifests in the bladder is different depending on the type of injury. Classically, injuries that happen in the brain and spinal cord, the upper motor neurons, result in a small, high pressure contractile bladder. And lower motor neuron injuries can either cause lack of sensations, so an insensate bladder, and a low pressure, sort of large, floppy, more atonic bladder. That's not always true, but those are sort of generally the differences between the types of injuries that occur neurologically and how they manifest on the bladder. And importantly, the innervation to the urethra is very low in the sacral spinal cord. And so if an injury occurs that disassociates S4-5 from the remainder of the bladder innervation, you can have a condition called detrusor sphincter dyssynergia, where the bladder is able to contract, but the sphincter fails to open up because it's been severed, because the nerves to it's been severed and therefore or disconnected, and therefore you have a bladder contracting and the sphincter failing to open up, and that can be quite dangerous for ultimately for renal function. And so this is sort of just a general readout of what we get when we look at urodynamics, and I'll just walk you through this. So what you can see here, and this is sort of like a brain injury or spinal cord injury, sort of classic neurogenic bladder. Here's the PVES, which is the pressure seen by the pressure transducer that's in the bladder. Here's PABD, which is the pressure seen by the pressure transducer that's in the rectum, and PDET, which is the subtracted pressure between the two of these. And what you see here, you want to look at the detrusor pressure, and what you see here is that while a normally innervated bladder, the pressure stays at or near zero through filling, you see in this particular patient, the pressure starts to rise quite early at a volume only around 39 cc's, and then it climbs up to near 50 at a volume of 105 cc's. and sort of stays. So that's a patient who has what we call a poorly compliant bladder. The pressure rises quickly and remains sustained. And this patient, and the reason why we get concerned about that is because high pressure storage can lead to upper tract deterioration, right? So we sort of think classically of pressures that are sustained above 40 millimeters of mercury can result in renal deterioration through time, secondary reflux and renal deterioration. And here we've also measured the sensations. They're marked up here. Here's the first sensation in this individual. It just, it looks like that's about 89 cc's, first desire, and then they're leaking here around 50. You can see this patient leaks here. So that's a very poor, very poorly functioning, what I would say classic neurogenic bladder of a patient with a spinal cord injury. And importantly, I use video urodynamics. And so as we go through filling, we take pictures. And this patient here has what I call a popcorn bladder. You can see these little diverticuli outside. And this, even without seeing a tracing on this individual, just seeing this VCUG, you can tell that this patient has a very, very poor functioning bladder. So I will tell you that if you don't have urodynamics available to you, if you do a cystogram and you see this type of bladder, this is a very hostile bladder. We call this a popcorn bladder, or this, which is sort of what we call a Christmas tree bladder, because it's shaped like a Christmas tree. In this condition, in this situation, this patient also has DSD, because you see this very dilated posterior urethra and a closed sphincter with filling. The patient prior had an open bladder neck from spina bifida. And this is what I sort of think of as more like a lower motor neuron type of injury. This is a patient who had nerve injury following pelvic surgery, but this is classically what you would see in patients who've had maybe prolonged birth and had pelvic nerve crush from that, who've had pelvic surgery, or alternatively, good morning, Dr. Adai, or lots of patients with cerebral palsy will have this phenotype. And what you see here is the PDET. Again, we look back at the pressures in the bladder, and you can see that the pressure stays at or near zero all the way through filling, all the way up to a pretty high volume. This patient ultimately ended up voiding 700 cc's. And then at the time of permit to void, the patient is pushing in an attempt to void and recruiting Valsalva effort. So they're using their abdomen to try to void because the bladder itself is hypotonic or atonic. So a a second definition of neurogenic bladder, which I sort of call as type 2 or hypotonic neurogenic bladder, is a patient typically with a very large capacity with excellent compliance who uses Valsalva assist or Crede voiding to empty. And these patients tend to not be at risk for renal deterioration because their bladders store at low pressure. They tend to demonstrate recurrent UTIs and the problems that come along with incomplete emptying and large volume bladders. And again, if you look at video urodynamics or VCUG on these patients during this study, what you see is a large, smooth-walled bladder that doesn't have those diverticulae and can or cannot empty to completion. The bladder neck does open typically. This was a patient with spina bifida who had a very low-level lesion, who had a weak bladder, but was able to void with Valsalva to completion, and he had an artificial urinary sphincter placed for control of his incontinence. This is a patient with CP also with this type of neurogenic bladder. You can see there's a lot more activity because this patient's very spastic. And then you see this patient pushing to empty, but you see a very large capacity, 700 cc's here, low pressure bladder. And ultimately, this patient emptied with a large detrusor contraction. That's pretty typical in patients with cerebral palsy or with any kind of spastic neuropathy. This is a patient I just saw last week, actually, so I added it in. And something that my partner, Sean Elliott, has talked about that some patients with CP actually have classic neurogenic bladder and have to be surveilled. And so this was a patient with neurogenic bladder. You see has a pretty large capacity bladder, 550 cc's, but you see after about 465 cc's, this compliance starts getting pretty poor, all the way up to a pressure of, around 50 millimeters of mercury before leaking right here and emptying. So that brings us to our first case, and I'm going to ask Dr. Adai to introduce this patient and give the history. Good morning.
Yeah, thank you, Dr. Hadley. This is a case of a 42-year-old male who presented with difficulty in passing urine of 6 months duration. History of presenting complaints: the patient had been well 6 months before presentation. Patient noted straining at urination. He had poor stream of urine, incomplete bladder emptying, post-void dribbling, and nocturia infrequency. He presented in urine retention, and an ultrasound done showed a thickened bladder wall, trabeculations, prostate volume of 40 grams, and post-void residual urine volume of 830 mils. Catheter was successfully passed. Now, the past medical history was okay. There was no proud trauma to the spine, no congenital spinal valve defects, and he had PSA, which was normal for his age. This patient underwent a transurethral resection of the prostate, but he continued to experience voiding and storage symptoms after the urethral catheter was removed. We then put him on botanical, 50 milligram TID. There was no improvement. And patient has been on clean self-intermittent catheterization for the past 8 months and is currently happy with his urinary symptoms. Yeah. So the question to ask about this patient is, what is the differential diagnosis? And looking at the patient's age and the relatively small size prostate, should he have undergone urodynamic study prior to the TRP? And could the symptoms be as a result of bladder dysfunction? And when is botanical a parasymptomatic used in the management of neurogenic bladder? Thank you.
Thank you. So we might not answer all of those questions, but I just wanted to sort of run through a couple of things that came up to me when I heard this story. Now, first of all, we see this commonly patient with urinary retention in an older population who may have advanced prostate cancer or advanced BPH. But in a young person, urinary retention is quite rare unless there is some sort of obstructive phenomenon like a urethral stricture. So I've included how I sort of think about the differential in these patients. In a patient with an atonic bladder, that can be due to neurologic conditions like a B12 deficiency or diabetes, spinal shock, obviously that would be preceded by some sort of traumatic event, a lower motor neuron injuries like pelvic surgery, an overdistension injury, medications like anticholinergics or sometimes over-the-counter cold preparations that may have a component of anticholinergic medicine in it, like antihistamines and that sort of thing, or something we term in this country Fowler syndrome, which is typically only seen in females, and this is atonic bladder that sort of occurs out of nowhere. We can also see it in obstructive phenomena like BPH or bladder neck contracture, primary bladder neck obstruction, which is commonly seen in young people in their, maybe even sometimes in their teens and 20s. Detrusor sphincter dyssynergia, which implies that there's a neurologic cause of the sphincter in the bladder being dyssynergic, or what we call pseudo detrusor sphincter dyssynergia, also known as Hinman voiding, which is congenital. That is a situation where the bladder and the sphincter never learn to coordinate at the time of voiding. And those patients are dysfunctional voiders, such that when the bladder pushes down, the sphincter fails to open up. And these patients often progress to renal insufficiency and deterioration at a young age in their childhood or in their teens or 20s. Urethral stricture, and then of course, prostate tumors or tumors of the posterior urethra like rhabdomyosarcomas. So that's sort of like broadly the differential. Of course, this patient was younger. I do want to speak to the Bethanechol. This is a direct parasympathetic. It has M3 receptor, the M3 receptors on the bladders where it works, and it's also has uses for patients that have exocrine gland dysfunction. I will tell you that it can have pretty significant side effects, and I've never actually seen it work. So I believe people tell me that they've seen it work, but I do not use it as part of my practice because I've never seen it work well enough to get someone's bladder to start working. And the side effects, of course, can be significant. So I typically don't use this medication, but and it didn't work in this man. I don't think it's horrible to try it, but I just think that it often is not fruitful. Do you have an opinion about that, Dr. Adai?
In terms of the side effects profile?
Yeah, about the utility of Bethanechol in patients with atonic bladder.
Well, I've also realized that you really don't get much improvement with the patient's voiding symptoms, voiding when you put them on Bethanechol. But sometimes we are just lost. We don't have any other option than to be seen to be doing something by putting them on the Bethanechol, actually. In the worst case scenario, then I'll put the patient on the clean intermittent catheterization.
Yeah, and I appreciate that catheterizing in maybe not in the cities, but in resource poor areas in the countryside and that sort of thing can be substantially more challenging where you live and in parts of the United States where patients can't get access to things like disposable catheters and that sort of thing. So obviously the environment can make intermittent catheterization substantially more difficult. So I think we didn't cover all of those questions, but I think we covered most of them. So in this particular patient, a 42-year-old male found to be in retention, what do you think was his diagnosis in retrospect?
I think so, looking at his capacious bladder volume, it was likely a neurogenic bladder.
Neurogenic bladder. Maybe
because
from...
actually, it couldn't have been a stretcher because the catheter went past easily. And it couldn't have been just the obstructive BPH because the prostate volume was also small.
Yeah, if I was a betting person in a 42-year-old, I would say this probably from primary bladder neck obstruction. It's sometimes those patients, but typically those patients do respond to a transurethral resection of the prostate. Of course, long-standing obstruction can secondarily change the bladder and make the bladder not work well, as we see in patients with prolonged BPH. And so sometimes even after alleviating the obstruction in a young patient with long-standing obstruction, the bladder, fails to work well.
Okay.
Should we go through case 2?
Okay. So this is a case of a 35-year-old young man who had a minor crash injury to the back. Actually, it's a minor, and was operating the machine. And the machine with an object that has been lifted, hit him from the back. And he came to the emergency with inability to walk, and was also in urine retention. At the emergency, he had emergency laminectomy and rehabilitation. Patient was able to walk after 2 weeks. He continued to experience difficulty in passing urine following the catheter removal after the laminectomy, and had severe straining at voiding, poor stream of urine, and incomplete bladder emptying. So the neurosurgeon referred the patient to urology, where ultrasound evaluation showed a thickened bladder wall with trabeculations and mild bilateral hydronephrosis. Patient had an MCUG done that showed bilateral vesico-urethral reflux. Patient was put on Betanicol. There was no improvement in symptoms, and therefore we had to initiate clean intermittent catheterization. But occasionally, patient present with ongoing dysuria, and over time, his need for clean intermittent catheterization has declined, as is able to void freely in between periods of CIC. And so he realized that over time he could void without this catheter. Now, the question I wanted to ask were, what happens to the bladder acutely following spinal injury? Would you want to answer the questions one by one, or do you want me to run through them?
Sure, we can just keep coming back to this list. So, because they are going to be hard to remember them all. When we think about spinal injury, we sort of think about two periods. The initial period, which we term spinal shock, which typically lasts about 2 to 3 months. We sort of generally think after a year, the spinal shock period is over. And in that scenario, the bladder is atonic. It doesn't work, it doesn't respond, it's insensate. And typically through this period, we do recommend intermittent catheterization as was recommended for this individual. And then following the period of spinal shock, there is some change to the bladder. It can start working again, and may even, in particular, if you have a therapy like a laminectomy, may be able to regain some sensation, or it may progress to sort of what we think about as a classic neurogenic picture: poor compliance, overactive, high pressure. And in that scenario, those patients, I typically do follow urodynamics in those patients and follow them pretty closely, particularly for the first couple of years after their injury. There is something called autonomic dysreflexia, and this is a really important thing, which wouldn't have been the case with this man who had a very low injury. But at lesions that are at or above T6, what happens is there's a disconnect between the autonomic response in the spinal cord to sensations that happen below the level of the lesion. And so anything that happens that is sort of an insult to the nerves below that, be that constipation, pain, a pain sensation, or commonly I see with bladder filling or erections, you get hypertension, which can be very, very, very high, headaches, sometimes secondary strokes from this condition. So it's any noxious stimuli that happens below the sensory level of T6. And these patients are particularly challenging and very important to follow, because if they have unregulated neurogenic bowel with a distended colon, or bladders that are not being appropriately emptied, they can have the secondary effects of unchecked hypertension, both the acute ones like stroke and that sort of thing, but also long-term effects of hypertension that we see. And this is a patient with a classic sort of finding after 2 years following spinal cord injury. Again, we see the P vest, the P abdomen. We want to look at this P det here. And you see immediately this patient only has 6, less than 10, it might be 8. So maybe 10 cc's of urine in the bladder. And then you see this compliance just immediately start to change. And by the time we have 123 cc's in the bladder, just 4 ounces, this patient has a sustained pressure around, 30, 35 millimeters of mercury. And then at the permission to void, again, at a very low volume, only 150 cc's, this patient is wildly attempting Valsalva maneuvers. This is the abdomen pushing down to try to empty, and then the catheter is removed. And the patient continues to Valsalva void here, and you see you get small staccato type pattern on the flow. This is the flow. So you see the patient was able to void a little bit with the catheter in here. And then once we remove the catheter, that's why the pressures disappear here. You see this patient continue to Valsalva void. And this is just an example of what secondary reflux looks like. So if the pressures are sustained in the bladder, then that the natural valves that occur where the ureters traverse through the detrusor muscle sort of get distended away or blown out, we like to say. And then you can see here this sort of poor looking popcorn type bladder that has secondary reflux up here. This patient actually lost his kidney and had a simple nephrectomy. So you see this pretty long, and he was having problems related to this little fragment of ureter that was refluxing. So what can we do to improve compliance or in that period of time following spinal shock? Well, bowel management is a critical piece of this, because we know that if the bowel is chronically distended, particularly the sigmoid and rectum is chronically distended with impacted stool, the bladder's not going to function well. It's going to be more hyperreflexic because the colon is pushing in on the bladder, and it will also store at higher pressures and predispose that patient to recurrent UTIs. So bowel management is a critical aspect of that. And these patients, I usually ask about their bowels every single time, ask what their bowel regimen is. And they often have to be on things like lactulose and other products to keep the bowels loose and moving, because the muscle of the bowel no longer propels the stool forward. So, and even sometimes they need to go to enemas to sort of mechanically remove the stool, particularly from the lower colon, from the rectum and the sigmoid colon. Anticholinergics are a mainstay of treatment. Tricyclics and antispasmodics like baclofen can also be helpful. All of these medications, of course, promote constipation. And so if you're going to start a patient on an anticholinergic like oxybutynin, you also have to be talking to the patient about their bowels, because there's going to be a trade-off there. And then beyond these two, which I always think every single patient is on these medications who has a classic neurogenic bladder following spinal injury, we can inject Botox into the bladder cystoscopically, and I have a lot of patients in my practice that get Botox injections. If they have DSD, detrusor sphincter dyssynergia, you can also inject Botox into the external sphincter. And so I have a couple of patients who have DSD and have neurogenic bladder who get some injected into their bladder and some injected into their sphincter. There are surgical options as well, including a posterior sacral rhizotomy, which is going to just disconnect the bladder entirely from the spinal cord and convert it into an atonic bladder, or augmentation cystoplasty, of course, which is a much more substantial operation and requires very, very close follow-up and catheterization for life. So in patients for whom compliance is okay, and they can have a reasonable dry interval, intermittent catheterization is fine. Crede voiding is also okay if their compliance is okay and their voiding pressures aren't too high. Some patients have what we call reflex voiding, and that is voiding that occurs by either scratching the leg or tapping on their abdominal wall, which can basically cause a detrusor contraction. And that's fine if their compliance is okay. If the patients have poor compliance, like what I showed you on the prior tracing, and they're reliable with their intermittent catheterization, that's one option. Of course, in conjunction with bowel management, anticholinergic management, et cetera, et cetera. If they are not reliable or don't have access to catheters, then, you know, suprapubic tube diversion or urinary diversion or an augmentation cystoplasty is usually the next step. And I understand that it's much more complicated to do that in a situation where access to appliances for ileal conduits and catheters is more challenging. And that was actually that's been the biggest thing for me when I go to Rwanda, that the patients that I would normally just automatically divert because of where they live and what resources they have access to, it's much more complicated to get them to have appropriate management of their bladder. Patients with neurogenic bladder, with ones that are on intermittent catheterization and ones that that are, you know, just Valsalva voiding, but maybe possibly incompletely emptying. You know, UTIs can be very problematic, and UTIs in a patient with neurogenic bladder are very common. On average, they happen 2 to 3 times per year. I tell patients, you know, it's normal to have an infection 2 to 3 times a year. If you're having it more than that, we need to talk about what you're doing and what we can do to head it off. It's the second most common cause of death in patients with spinal cord injury in my country. But importantly, it's only defined by a patient who has symptoms. So unlike a patient who doesn't have neurogenic bladder, if they have a positive urine culture, that is not a positive UTI unless the patient has symptoms. And these are the criteria I typically use to define a positive UTI. I ask all my patients with spinal cord injuries or any other neurologic deficit, what are the symptoms you have when you have a UTI? Patients who are insensate, it may be a headache, it may be lethargy, it may be autonomic symptoms like headache and hypertension. But sometimes, but very commonly, it's not sort of classically what we think of, like dysuria and the things that we think of in a patient with normal sensation. So I always tell patients, those are your symptoms. That's your sign that we need to go get you cultured and get you treated. This is from a Urologic Clinics of North America article from Max McKibben that I really liked. It sort of goes through the algorithm. And I think hopefully this talk will be available so you can copy this if you want. But it basically goes through an algorithm for patients with neurogenic bladder who show up with a concern for UTI. Of course, urinalysis and culture are the first steps. If the patient is not symptomatic, we call that asymptomatic bacteria. We don't treat. If they have a fever, and then typically we oftentimes admit them to treat, to hydrate and to treat appropriately with broad spectrum antibiotics. If they're not unstable, we can treat them in an ambulatory fashion with antibiotics after culture for either 1 or 2 weeks. And again, this is just in patients with neurologic conditions, with neurogenic bladder, because of course, patients without neurogenic bladder, we treat for much shorter courses. And what do we do for the patient who has, recurrent UTIs, who it may be catheterizing or have an indwelling suprapubic tube at times? We talk about catheterization technique, clean hands, if possible, using a new catheter, minimize the amount of dwell time that the urine has. So if they're only cathing twice a day, increase their catheterization interval to 3 or 4 times a day. Particularly if it's the same bacteria over and over, like it's Proteus, 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 you want to think about, is there a stone somewhere in the system that could be harboring that bacteria? And that's true, particularly in urea splitting organisms like Proteus. Bowel management, like probiotics, these things all have variable data to support them, like probiotics, cranberry, D-mannose, ascorbic acid, and irrigation. I actually tend to go first to just irrigation with clean water to try to wash out debris and prevent the urine from dwelling in there, the bacteria from dwelling in there too long. It's recommended, and I certainly in my practice avoid antibiotic prophylaxis at all costs, but some patients need it, so, particularly if they have any form of immunosuppression. I think the best options are either trimethoprim, nitrofurantoin, or sometimes even just one, single dose amoxicillin daily, all of which are pretty low impact on the bowels and tend to not cause a lot of resistance. Augmentation cystoplasty is, obviously much more invasive approach, and these are for patients who are reliable, who are going to come back for follow-up, who are going to routinely catheterize and irrigate their bladder out. And this is just a picture of what you do. You sort of clamshell the bladder open. How you clamshell it depends on if you're going to make a channel for the patient to empty, detubularize the bowel, and retubularize it into a U patch. When I think about a patient who may need augmentation cystoplasty, there's really 3 questions to ask. What bowel segment are you going to use? Because it's classically described with ileum, but sometimes colon patch is more appropriate, in particular if a patient's already had a diverting colostomy and may have a defunctionalized segment of sigmoid colon just sitting in the bowel unused. Whether they need a channel to help them empty, and those are particularly relevant for patients that are in chairs and female patients who cannot catheterize as easily into their urethra. And if the bladder neck is open and they're leaking, if you need to address the leakage at the bladder neck. And so those 3 things are the 3 questions I always ask when a patient comes in who may have a really poor quality bladder and may be leaking. Of course, those patients usually have secondary problems like wounds from the urine leakage or other problems. So let's just go back and see if there are any of these questions that we need to answer. I think we have generally most of these things. I will tell you, in a patient following injury, I typically assess them the first time when I feel pretty confidently that they're out of the spinal shock period, when they start to regain some function. And then we put them on a pathway. So maybe that's intermittent catheterization 4 times a day. And I'll get into this, but if things start changing, if they start having more leakage of urine or having less leakage of urine or having escalating UTIs, that's usually when I reassess them. I don't routinely reassess them at any given interval. And then we talked about prophylactic antibiotics and enterocystoplasty or augmentation cystoplasty. And then the bowel management. I think we addressed most of these things in this. Okay, we got a couple minutes left for the last case. Take it away, Dr. Adai. Are you on mute? Dr. Adai?
Hello, sorry.
Yep, there you go.
I will appreciate it when you are addressing the questions for this case, that you make reference to the question, because sometimes I realize that you address all the questions all right, but you go back and then you have to situate it into the question that was asked. And so I appreciate it if addressing each subject or the question is read first before you address it. Thank you.
Okay. All right.
The last case is a case of recurrent constipation and straining at urination. Okay, so this is a 7-year-old girl who was born with a spina bifida. I think you jumped a little because I can't see the beginning of the history, but I can remember it from my head that this patient is a 7-year-old girl who was born with spina bifida. She also had some deformities of the lower limbs. And the main problem when she was brought to me were recurrent constipation and poor stream of urination, poor stream of urine and straining at urination. The child looked small for her age. In fact, the child that came after her was almost twice as grown as her. I did an ultrasound that showed a normal bladder capacity with insignificant residual urine volume. And patient had no hydronephrosis. And she had recently undergone spinal surgery and was able to ambulate. Patient has been on long-term oxybutynin by the pediatric nephrology team. Next slide. Now, the question is, what is the role of the urologist in the management of a patient with congenital spinal defect? And
Okay, we'll go back and forth to these.
Right.
I will tell you that I did include the spina bifida recommendations, the Spina Bifida Association recommendations for these patients by age. And these can be found online. I'm happy to provide anyone with the link if you would like them. But these are the recommendations from birth to 3 years. First, initiate intermittent catheterization and put the patient on anticholinergics. We typically use oxybutynin. I don't do pediatrics, but that's commonly used. It's the cheapest one available here. A renal and bladder ultrasound, urodynamics, and serum creatinine at about 3 to 6 months of age. And then a ultrasound, renal and bladder ultrasound every 6 months thereafter until about 2 years. And it's recommended these patients get urodynamics yearly. Okay. After 3 years, it's recommended these patients just get a renal and bladder ultrasound and only urodynamics if there are upper tract changes, UTIs, or a change in the continence pattern of the individual.
Okay. My sister. Oh, okay.
Hadley, I think Dr. Boa has a question.
From Uganda.
Okay.
Hello.
Dr. Kigango, we can hear your feedback.
Go ahead.
All right.
Dr. Aboa, do you have a question?
Yes, I do.
Okay.
What is the in treatment of these patients?
What is the treatment?
Role of neuromodulation. That is implanting these electrodes in the spine, in the spinal cord. Neuromodulation.
Yeah.
I hope you've heard of that. What is the role in management of these patients?
Mm-hmm. So in patients with spina bifida or spinal cord injury.
Not specifically spina bifida, but neurogenic bladder.
Yeah. So what you're talking about is probably what we call the most common. There's actually quite a few systems. The one that's most commonly used here is the InterStim device by 3M. And I will tell you that I do not find sacral neuromodulation that helpful in most of these patients. So we know it doesn't work in patients who have obstructing neuropathic bladder. So that would be patients with BPH, urethral strictures, et cetera, primary bladder neck obstruction. It most commonly works in patients who have detrusor overactivity and urinary incontinence secondary to that, but good compliance, and who store and empty at low pressures. So, or in patients who have idiopathic urinary retention, so-called Fowler syndrome. So I will tell you that it's pretty uncommon for sacral neuromodulation to work, particularly in men, in adult men, because they void at higher pressures and they tend to have obstructive neurogenic bladder because of the prostate. So actually, I don't even do these procedures. If I have a patient that I think is appropriate for sacral neuromodulation, I actually send them to my colleagues who do female urology, because they do a lot more of them in the female population who have sort of idiopathic detrusor overactivity with aging, or who have Fowler syndrome. So I have hope actually that at some point in our lifetimes, probably we will have a neurologic electrode type of, you know, an electric solution to many of these problems, but we don't currently have anything that is reliable in patients with sort of classic neurogenic bladder.
Okay. So it's more useful in females then?
Mm-hmm.
Okay. Thank you very much. That was a good lecture.
Sure. Do we have, it's 7 o'clock. Should we keep going, or do you, I know I've said, I don't know what time it is over there, but I know it's not the beginning of your day. So we can keep going if you want to finish this off, or should we just wrap things up?
If you're done with your slides, probably
let me just run through this case a little bit more, because I think spina bifida is, you know, particularly interesting and challenging because these patients change throughout their lifetimes. We talked a little bit about sort of early life, but things that we don't think about as the patients transgress through puberty is that serum creatinine can really change. And we know in patients, particularly patients who are non-weight bearing, patients that are in chairs, that serum creatinine is not a good way to measure kidney function because they're not generating creatinine. And we don't have, even in this country, we don't have a reliable, affordable way to measure, you know, GFR, total, you know, kidney function that is not based on a creatinine-based method. We are in some places using something called cystatin C, which may be a little bit more reliable, but the jury's a little bit out. So I do order that on my patients. And it's important to measure B12 in patients who are more than about 5 to 10 years out, especially if they've had use of any of their ileum, for example, for augmentation cystoplasty or bowel diversion, or patients that have short gut conditions like you know, Crohn's disease, or they've had bowel resected from it. Maybe they had a multi-system trauma that results in a spinal cord injury, but also bowel resection. Those patients may have B12 deficiency, and that, of course, can cause neurologic damage and continued loss of bladder function through time. In adults, it's a little bit different. And this is what I was sort of referring to before when we think about when to pull the trigger and resurveil them, particularly with urodynamics. And I usually think of these as the big markers of when the system is changing. If they have new leakage, particularly nocturnal leakage, if they have a decline in their kidney function, new hydro or rising creatinine, or if they start getting escalating or new urinary tract infections. So previously they got maybe 2 to 3 per year, and they come to see you and they've had 7 or 8 back-to-back infections. Those are all reasons that you need to pull the trigger and reevaluate them. And if urodynamics is going to be part of that evaluation, the most important thing to know is that it's only useful if you know what question you're asking. Okay. I'm going to skip through some of these things because these are just more examples of patients with adults with spina bifida. I'm happy to like come back to this if you ever want to do more of this topic down the road. But in general, I always think of patients, adult patients with spina bifida, you know, they are also changing, you know, they are just like every other adult, you know, they're getting things like BPH, they're getting pelvic organ prolapse, they're having other changes to their spine, like spinal stenosis and that sort of thing that are age-related phenomena. And because their bladders in pediatric life are often decompensated and they've often developed secondary ways to manage their bladder, like they're Valsalva voiding, or they have poor capacity already, or maybe they already have some instability. When you add on those secondary changes through adult life, they can have even more pronounced effects. And that's why these patients are particularly critical to sort of really understand what the system is doing, so that as life changes, like it does for all of us as we age, we can layer on top of what their risk may be of renal deterioration. And I still see this year, I mean, even though I surveil these patients very closely, I still see a handful of patients every year who lose their kidney function and progress to severe CKD because they've had a secondary urologic phenomenon on top of an already sort of not well compensated urologic system. So just to conclude, you know, when you see a patient like this, the voiding pattern and the history are really important. You know, if the patient's having massive volume emptying at once versus small amounts throughout the day, that sort of tells you that a large volume may be more like an atonic bladder that empties, you know, with a large bladder spasm, versus small amounts that trickle out through the day. That could be a poorly compliant bladder that just is sort of spilling over the top every time it has a contraction. I think it's helpful to know what the expected patterns are based on the history and diagnosis. Does the patient have spinal cord injury? Does the patient have spina bifida? Does the patient have a muscular dystrophy or CP? Or have they had a traumatic injury? Because the patterns can help you sort of think about what you expect this patient should have wrong with their bladder and with their outlet. And I use video urodynamics more commonly than standard urodynamics. And I know that that's a luxury for me. Even here, most urologists don't have video urodynamics, but I think the images are really helpful. And so if you can get, you know, pictures, just cystogram pictures or avoiding cystogram pictures of patients, that may be an important clue to how neurogenic a patient's bladder is and the status of their bladder neck. And I think that's it. I'm happy to take, it looks like Dr. Kagongo has a question. Do you want to go ahead and ask that?
Yes, thank you very much, Doctor, for the presentation. I really apologize for joining late. We had some time challenges in Uganda. We are only 2 so far, but I think many of the people will watch the recorded video. I have 3 questions. I've typed one of them. That, do you make a distinction between these 2 terms, voiding dysfunction and dysfunctional voiding? How important is that? Then, yes, okay.
So you're asking, so dysfunctional voiding, ask that question again. Let me just make sure I understand it.
There's some literature which defines voiding dysfunction, a different disorder, then dysfunctional voiding, a different disorder. Are they really different?
Yeah, I mean, I usually think of, no, those 2 things I think of as the same thing. And that's what I typically think of as a patient with like Hinman bladder. When we sort of go back, I can go back to, let me just pull up that slide. Typically, I think of voiding dysfunction of when the bladder pushes down in an attempt to empty, but the pelvic floor or external sphincter fails to open up. Okay. And that's what we call sort of pseudo detrusor sphincter dyssynergia, because what you have is a bladder pushing, sphincter failing to open up, and then you get that the high pressures associated with the bladder trying to empty, sometimes transmitted up to the kidneys, okay? That can cause the bladder itself to remodel, get thick-walled, become unstable in terms of having phasic contractions. And that's what we see in patients who are born with this problem. Patients can also acquire dysfunctional voiding, and that often happens, particularly in men in young adulthood, associated with prostatitis, pain syndromes, pain with ejaculation. You sort of see this whole wastebasket. Those patients are less likely than patients who are born with Hinman bladders to like progress to renal deterioration, but they need treatment for that. And that treatment, at least in my practice, I typically use biofeedback, pelvic floor physiotherapy for those patients, because they have to relearn how to relax that bladder. Now, sometimes injecting Botox into the pelvic floor can help, or trigger point injections can help them relax it, but their brain has to rewire so they can relearn how to properly void.
Okay, thank you. The other question, I needed the clarification about a case where you say the patient had symptoms because of the reflux into the ureter. The patient had a symponephrectomy and the remaining ureter. Which symptoms does it give?
This particular patient was getting recurrent UTIs. And that sort of goes back to what I was talking about with UTIs, is it was the same bug over and over. And so what that told me is that their urine was going to somewhere in the urinary system and sequestering. And when I saw this, this VCUG on my urodynamics, it was obvious what the problem was, because when his bladder was empty, this remnant would not completely empty. So of course, if you have E. coli in your bladder and you're pushing it up here and you're treating a patient with antibiotics, you can clear the bladder, but you cannot clear this remnant. This patient also had a pretty neurogenic bladder, and he ended up, he was a more complicated situation. He'd had a prostate cancer treatment and that sort of thing. So we ended up doing a ureterostomy on him and augmenting his bladder. So we made his bladder bigger here with a patch, and then we used this ureteral remnant, which was not being used for anything and was actually causing him trouble as his catheterizable channel.
Okay, thank you. The last question is about the insensate bladder. When you use that term, insensate, do you mean the lower motor neuron lesions, or it can occur in the upper motor neuron injuries?
Yeah, when I think of an insensate bladder, I sort of think of that sort of second phenotype, the very this type of a bladder that just doesn't ever signal. So the patient gets to 500, 600, 700 cc's, and they're not even saying, oh, I have a sensation that my bladder's filled or I need to void. And those bladders typically are safe, but they're problematic because they often incompletely empty. And so they're set up for recurrent UTIs, but they're not, these bladders tend to not be the types of bladders that that result in renal deterioration. And we also see this pattern, in patients who've had long-standing BPH, who come in, they've got 2 liters in their bladder, and you start filling them up, and you get to 800 before they report even their first sensation. That bladder's never going to recover function and never going to empty appropriately, even if you do a TURP on that patient. I usually still end up doing a TURP because you don't have a lot of other options, but that bladder the damage has been done. We also see it in diabetic bladders, right? Poorly controlled diabetic bladders.
Okay, thank you very much, though.
Sure. So I welcome feedback, and if any of you have any questions or anything, please feel free to send me an email address. My email is woodh@ccf.org. I don't have it on my title slide, but we can, Danielle, can you make that available to anybody that, and Dr. Adai has it. So anybody who would like to send me any questions or anything, I'm happy to review a case or whatever.
Absolutely. And we'll have your lecture both up on our website and on our YouTube channel. So it'll be archived So if anybody wants to go back and watch the thing, the video in its entirety, it will be there. So, and if you have any questions, and too, you can always email us through IVU. We'd be happy to put you in touch with Dr. Wood.
Well, thank you everyone for joining me today. I hope you have a good afternoon.
Yes, thank
Danielle,
you.
I hope you have a good day. Thanks for
Thank
getting
you.
up at 4 a.m.
Thank you very much. Thank you
No
so
worries.
much. It's great. Thank you.
Bye-bye.
Bye, everybody.
Bye.